Yep, getting thumbs up. Perfect. All right, everyone, we'll get started. So I'll just ask everyone to take a seat. Welcome here tonight for our Falls Forum. My name's Jo Mania. I'm Program Delivery Lead of our Injury Prevention team at Injury Matters. Very excited to welcome everyone here tonight for our Falls Forum event. Tonight we host this event on Whadjuk Noongar country to come together, share knowledge about falls prevention and build meaningful connections across the sector with each other. I'd like to acknowledge the Whadjuk Noongar people as the traditional owners of the land on which we come together tonight and pay my respects to the elders past and present. And I'd like to extend that to any Aboriginal or Torres Strait Islander people joining us in the room tonight or joining us online. So before we get started tonight, we've just got a little bit of housekeeping to get through. So for those that are joining us in person today, our toilets are located just across the hallway in the foyer. In case of evacuation, we just ask that you head directly outside the doors and just keep going straight. You'll see the emergency exit. Out of respect for all of our wonderful presenters tonight, we do ask that you please make sure that you turn your phones to silent. And we also do have quite a few people joining us online today. So just to make sure that everyone online can hear what's happening in person tonight, when we're asking questions, we do ask that you wait until a roaming microphone is passed to you before answering a question, just so that everyone can hear what's going on. We might be taking some photos throughout the night as well. So if that's something that you're not comfortable with, just shout out to one of our staff in an Injury Matters shirt and we'll make sure that you're not included in those photos. And for those that are joining us online tonight, welcome. You'll notice that your microphones are muted. This is to make sure that everyone can hear our presentations nice and clearly. If you've got more than one person joining us in the room tonight, we would appreciate it if you could just let us know in the chat tab. Let us know how many people are joining in the room with you, just for our own records. And if you have any questions for our presenters as we go through the night, please pop these into the chat tab again. And we'll take a few moments after each presentation to run through a few questions. And if you face any technical issues online during today's event, again, let us know in the chat box and we'll do our best to help you out. We do prohibit the use of artificial intelligence systems and technologies throughout tonight's event. So please note that any AI technology that we do see will be removed from the online part of this training. So just a little bit about Injury Matters before I get started. Our vision is for safer people and places, and we dedicate our work to preventing and reducing the impact of injury in the WA community. And we also support those that have been affected by an injury. And we do this through our key programs. So Stay on Your Feet, No Injury, and Road Trauma Support WA. And tonight we're putting our falls prevention caps on to deliver this event through our Stay on Your Feet program with support from the WA Department of Health. And for those that might be new to the Stay on Your Feet program, we provide information, training and support to both older adult community members and health professionals such as yourselves around how to prevent falls in the community. And we have three key messages that we use throughout our community engagement and workforce activities. And these are move your body, improve your health and remove hazards. And this is where we get our overarching move, improve, remove slogan from. So before we welcome our first speaker for tonight, I just want to have a quick look at falls in WA and what that looks like. So we know that falls are a significant public health issue in WA. That's why we're all here tonight. But let's have a look at what that actually looks like. Our 2025 WA Falls Report highlights that in Western Australia, someone dies every 17 hours, is hospitalised every 16 minutes, and presents to the ED every 12 minutes due to a falls-related incident. And we know that falls can have a significant impact on a person's life, to those around them, and also the burden that then places on the health system. I think it can get really easy to get caught up in that day-to-day of your jobs or looking at the numbers. I really want everyone to take a moment just to think about how each one of these statistics is a person that has been impacted by a fall or an injury. The day-to-day of your job matters, and you're all having an impact. These statistics are just a snapshot from our 2025 falls report. So if you do want to delve a little deeper into what that looks like, you can scan the QR code up on the screen, or you can also download the report from our Injury Matters website. So 2025 has been a big year for falls prevention. We've had the launch of the updated Australian Falls Guidelines. We've had the establishment of a National Falls Alliance in Australia. And more locally in WA, we've also had the launch of a new statewide falls prevention advertising campaign. But tonight we'll be having a look at the guidelines in particular. And the guidelines provide that coordinated approach to falls prevention across Australia, and then also providing that tailored falls prevention approach within the community care setting. And so while the community falls guidelines, as we know, have been complemented by hospital guidelines and residential aged care guidelines, tonight we'll be focusing on the community guidelines and applying that local lens here in WA of how we can integrate these into our work in the community. So I'm pleased to present a whole range of presenters tonight. I will just point out that we did previously have food and networking after our first presenter. We'll just bump that towards the end just so that those online aren't waiting around for us. So we'll have that at the end of the event. So I'll welcome our first presenter for tonight, Suzanne Butler. So Suzanne is the General Manager of Injury Prevention at Injury Matters, where she leads the Stay on Your Feet and No Injury programs and oversees injury prevention initiatives across WA. She has more than 15 years experience in falls prevention, helping to shape how prevention is prioritised, resourced, integrated into everyday practice. She works closely with partners across WA to strengthen prevention systems and support older adults to live independently and age well. Suzanne's actively involved in state and national falls prevention networks and is committed to practical, evidence-based approaches that make prevention easier to deliver in community settings. Welcome, Suzanne.
I think I need to simplify that one. Thank you very much. I wasn't the intended speaker for tonight's presentation, but please bear with me as I deliver information around the National Falls Guidelines or Community Care Guidelines. I will caveat my presentation with I wasn't involved in developing the guidelines, much more research-focused and evidence-focused people than I were involved in that, but I have read them, gone through them, and so hopefully I'll be able to answer some of your questions. If not, I'm going to go through to the number of experts that we have in the audience today. So these national guidelines, so preventing falls and harm from falls in older people, best practice guidelines for community care in Australia, that I will forever refer to for the rest of the night as the guidelines, just to make it a bit simpler. These are the first major update to the guidelines since 2009. So for those of you who've been around that long, will remember the green box, and those are the guidelines there. So we've been working for 15 years in Australia with no update to the guidelines in an area that's seen some pretty significant evidence increases and changes. So 15 years is a long time in falls prevention. And as I said, the evidence has shifted, our population is ageing, and our community services models have changed quite dramatically in that 15 years. So this update gives us a stronger, more contemporary framework to anchor falls prevention across Australia. And especially in WA, where we have a very diverse community and geographical spread. So my presentation is going to give a bit of an overview of the national guidelines. I will touch a little bit on the World Falls guidelines as well. We'll go over the recommendations within the guidelines and the good practice points and what the difference between those are. We'll talk about the WA context, and I'll touch on some general ways that you can use the guidelines and much more specific information around particularly 1A recommendations will be delivered by the other presenters this evening. And if there's any questions, as I said, I will endeavour to answer them or throw to one of the experts. So since the guidelines were released, there's, as I said, been some pretty significant updates on evidence on how to prevent falls within the community. And here's just a few of the Cochrane reviews, which we know are gold standard evidence. They're systematic reviews of primary research that are internationally recognised as a high standard for evidence-based information. So we have someone on interventions for preventing falls, multifactorial and multiple component interventions, exercise, environmental interventions, and as I mentioned, the World Falls Guidelines, which were released in 2022. So I'll be providing a bit of information in relation to those as well. So the World Falls Guidelines and the National Falls Guidelines are complementary. They're both older people centred and emphasise the need to involve older people, carers and family members in falls prevention, and both emphasise the fact that falls prevention is everybody's business. They're not competing documents. They serve similar but a little bit different purposes and sit at different levels of guidance. So the World Falls Guidelines were developed by around 100 experts in 30 countries and were published in 2022. They provide a global consensus on what good falls prevention looks like. They provide guidance across all settings, so community, aged care, hospital and emergency department. There's a strong orientation to frailty, multimorbidity and geriatric syndromes within the World Falls Guidelines, and they provide a universal approach that can be applied across all countries, so low, middle and high income countries. The high-level principles rather than detailed they have high-level principles rather than detailed implementation pathways. And one of their biggest strengths is the strong articulation of exercise fidelity, medication review, and the need for integrated care for older adults living with frailty. But because they're designed for global application, they are intentionally really broad. They don't account for the Australian health system, our funding models, or the roles within our workforce specifically. Whereas the National Falls Guidelines, in contrast, they're built specifically around Australian systems, particularly including Australian primary care, allied health roles and pathways, community organisations and Australian funding structures. Because of that, in the Australian context, they're more operational. So they also give you guidance on screening to assessment to intervention. They're more contextualised. So although both national and the World Health Organisation guidelines contain graded recommendations, the national guidelines interpret and apply those recommendations specifically for the Australian health and community system. They're more applicable to the day-to-day practice in a lot of situations for Australian clinicians, community workers and care services. And this guideline that we're talking about, of course, only applies to the community setting. So, the Australian Falls Guidelines versus the World Falls Guidelines, and I'm going to say that I stole this from Meredith's presentation, so thank you very much, Meredith. So they have both created an intervention algorithm linked to risk categories, so you can see there with the Australian guidelines, if someone has had less than a fall or no falls per year, they're considered low risk, and the recommendation is to support them to attend community exercise and undertake home exercise. For intermediate or increased risk is 1 fall a year. So We need to provide tailored supervised exercise programs from health professionals or appropriately trained instructors. And the high risk are 2 or more falls a year, and they are recommended to have falls risk assessment by a health professional to inform more tailored falls prevention interventions. Whereas the World Falls Guidelines, in contrast, an older adult who has no fall should be offered education about falls prevention and exercise for general health, falls prevention if interested. If an older adult has one non-severe fall plus balance and gait problems, they're considered intermediate or at increased risk. In addition to the above, they should be offered targeted exercise or referral to a physiotherapist to improve balance and muscle strength and reduce their falls risk. And those that have one or more falls, have an injury, are frail or are unable to get up without help, or have a loss of consciousness, should be offered a multifactorial assessment to inform individualised tailored falls interventions. I'm not going to go into too much specifics about the screening and assessment recommendations within the National Falls Guidelines. I'll leave that to the other speakers. I know they'll be covering some of that. On page 11 within the National Guidelines, it specifically covers falls risk screening and also using falls risk assessment for tailoring interventions. So falls risk screening is a quick process that aims to identify people at increased risk of falling and helps determine if more detailed falls risk assessment is required. And falls risk assessment aims to identify factors that increase the falls risk for that specific person that may be addressed through a falls prevention intervention. So one of the most important clarifications in the guidelines is the difference between screening and intervention. So many organisations and health professionals only conduct screening, which is fine, but screening alone doesn't do anything to lead to a clear referral pathway or an intervention. So assessments must be multifactorial, evidence-based and person-centred for them to be effective, and then connected to intervention. So within the World Falls Guidelines, there's 3 key questions that all health professionals are recommended to ask when dealing with older adults. So those 3 questions are: have you had a fall in the past year? Do you feel unsteady when standing or walking? And do you worry about falling? So it's really important that those are prompted questions. A lot of older adults won't disclose that they've had a fall, so it's really important that they are prompted for that. We did have a presentation recently at one of our research events where they did cover that some of these questions may not be culturally appropriate. So that's why a lot of the discussion that we're going to have tonight, and I'm sure the other speakers will be talking about the person-centred approach to falls prevention and interventions, and educating ourselves as much as possible on culturally appropriate discussions around falls. The one that I'm talking about in particular was with Chinese communities, and they noted that it was potentially inauspicious to directly ask someone, have they had a fall in the last 12 months? So when we are working with older adults, it's really important that we do have as much of an understanding about that person as possible so that we're framing our questions in the most appropriate way. So now to the National Falls Guidelines. So the guidelines themselves, has anyone not read the guidelines? No? No. I'm probably going to be repeating stuff that you already know then, but hopefully there is a bit of new information for some people. So the guidelines are a 30-page document. These ones, there is a 3-page fact sheet that goes with it, and you can also make a request directly through the Australian Commission on Safety and Quality in Healthcare for the 200+ page reference documents. So those reference documents contain the evidence. They do contain some resources and tools. And so if you are interested in having a much more in-depth look at the evidence behind them and further information, I recommend sending them, or it's actually on their website. Just complete a form and they'll send them to you. The 2025 Falls Guidelines recommend a greater focus on evidence-based falls prevention interventions for an older person's level and type of risk, and less emphasis on assigning a numerical risk, falls risk score. The recommendations and good practice points have been updated, incorporating new research, evidence, and addressing all aspects of care for older adults living in the community. The guidelines build on the previous falls guidelines, so it's not like a throw the baby out with the bathwater situation. They're building on it because evidence is progressing, but we already had some really strong evidence, particularly in the exercise space back in 2009. The strength of the evidence for each recommendation is indicated through the use of a modified grade approach, and so that's been based similar to what happened in the 2022 World Falls Guidelines. Some of the biggest changes include, obviously, the strengthening of evidence, particularly from those Cochrane reviews, and an increased emphasis on implementing interventions, so not just doing the assessment. A stronger emphasis on a systems-wide approach, better guidance or more in-depth guidance on screening to assessment to tailored interventions, and a focus on doing things well. So fidelity, dosage, and follow-up really matters. The strength of the recommendation is based on strong being number one, weak conditional being number two, and then the quality of the evidence being high at A, intermediate at B, and low at C. What I will say is that they've made it really clear that even if something is a 2C, it is based on randomised control trials. So any of these things that are in here still have good evidence behind them. There are the following terms used, as I said, to classify. We've got low risk of falls as less than 1 per year, increased risk of falls as more than one fall a year, and high risk of falls as 2 or more a year. So there are 14 recommendations related to exercise to prevent falls, home safety interventions, multiple component and multifactorial interventions, and single interventions that address specific risk factors. The guidelines also contain, as I said, good practice points. So those good practice points should be considered as they guide all aspects of care for older people in the community relevant to falls and falls injury prevention. And they're still based on research and expert opinion on good practice. Good practice points appear throughout the chapters, but they are not ranked by importance. So it doesn't mean if they're the top of the list, they're the most important. Some chapters include recommendations, while others solely focus on practice guidance. And an example of that is the continence section. So the national guidelines highlight that preventing falls in the community requires a multifaceted approach. There usually isn't one single factor that causes a fall, and most adults have multiple things that contribute to their risk. This slide is pulled directly from the guidelines, and it groups the key areas we need to consider when supporting someone. So their physical health, mobility, sensory changes, medical conditions, environment, and then what happens after a fall. The guidelines encourage us to take a tailored approach, assessing which of the risk factors are relevant to the individual, and then selecting the most appropriate interventions. So not every risk factor will apply to every person, but taken together, they provide a really comprehensive framework for best practice in falls prevention. I'm not going to go into depth about all of these. These are the recommendations directly from the guidelines. So you can see that there's some related to exercise to prevent falls, home safety interventions, multi-component interventions, and then single interventions for specific risk factors that have to do with things like podiatry, vision impairment, medication management, pacemakers, and osteoporosis and vitamin D. I know a lot of the other speakers are going to be covering specifically those recommendations. So applying the West Australian lens, it's really important that we have a look at the national guidelines from a West Australian perspective. WA has a set of demographic, geographic and systems level characteristics that are different from any other state in Western Australia. And the national guidelines can help support as a framework for us to be able to implement best practice falls prevention. Our older adult population is growing. It is growing fastest in our regional areas of regional and remote areas of WA, particularly in the Wheat Belt, Southwest, Great Southern and Goldfields. And when we look at the national falls guidelines through a WA lens, it's important that we see them realistically. The guidelines are not a solution to every problem that we have in falls prevention in WA, and they won't replace local knowledge, clinical judgment, or community-specific considerations. But they are a useful anchor to bring consistency to a state like Western Australia, where context varies significantly. In Australia, we have higher proportions of older adults living in areas with fewer services. We have greater prevalence of chronic disease and mobility limitations in regional and remote areas. We have larger distances between services in a lot of our locations, which make early intervention even more important. And it means that community-based clinicians often have to work across a broader scope, support clients who have fewer local options, adapt interventions to what's feasible in their local area, use telehealth, outreach, and hybrid models. And while the guidelines don't fix any of those issues, they can give you a structured way to think about risk and intervention regardless of the location. Programs like our program at Injury Matters, Stay on Your Feet, already support healthy ageing and falls risk reduction, and the program aligns to the efforts by providing a shared language for good practice, helping unify approaches across community, primary care, local governments and other NGOs, giving organisations a credible framework for reviewing their current practice. It's not about replacing what we're already doing in Western Australia, but ensuring that we've got evidence-informed practice within our systems. Tonight, there'll be a little bit more information towards the end of the presentation about joining the Community Falls Network that's organised by Injury Matters. We actually have a meeting tomorrow, if you're free, at 10 a.m. I really do encourage you. It is a fantastic way to connect to other people working in community-based falls prevention in Western Australia and sharing and understanding our issues, our concerns, resources, and also coming together to really push for a consolidated approach to falls prevention and advocacy within WA. The guidelines in particular are a really practical and everyday tool that can help answer questions like, what should I do first? Is the client in front of me someone who needs referral? What is the evidence base in this situation? And how do I make sure that I'm going to be doing the right thing for them? The guidelines support but don't replace good local judgment. And in WA, no single document can account for our workforce capacity, cultural considerations, regional service gaps, transport issues, and other things that we face every day. But as I said, a shared foundation that practitioners can use to identify interventions. The real value comes from how you apply the principles within the constraints and opportunities within your own communities. So this is the so what? Well, how do we actually use them in day to day? So they're a framework, they're a guideline, they're not an implementation plan. So they're helpful to help you understand where you sit in a pathway. The guidelines make it easier to see when screening should occur, when a more detailed assessment is needed, and when referral is appropriate, how interventions should look and how people should be followed up. You can look at the pathway and identify your contribution and where other providers fit in around you, but establishing that pathway is very local. So establishing a statewide falls prevention pathway is not realistic at a macro level. The guidelines can help provide clarity on what good practice looks like. The guidelines offer clear recommendations, validated tools, and evidence-aligned approaches. They help reduce uncertainty and variation, so you don't have to guess what best practice is or rely on ad hoc approaches. They support consistent communication across different services using the same definitions, screening questions, assessment tools, and terminology, which can help make collaboration smoother. When everyone's working from the same reference points, we hope that referrals will become clearer, expectations will become clearer, the client gets a more seamless experience, and communication between health professionals continues to be strengthened. They can help you recognise when someone needs to be escalated or referred. They can help give you structure to adapt best practice to your local context, and they can support quality improvement and workforce development. So teams can use the guidelines to review existing processes, update forms, workflows or tools, identify gaps in practice, build consistent onboarding and training processes, and they help align the work that you're already doing with contemporary evidence. But as I said before, there are some limitations. So they provide limited guidance on culturally secure models, particularly for Aboriginal communities and culturally and linguistically diverse communities. They provide limited practical guidance for regional and remote contexts, and they assume that there is access to professionals such as allied health professionals and services and in-home assessment and modification services. And there's limited direction on implementation. So they can tell us what works, but they don't necessarily tell us how to implement in our community's focus. So in that mind, they are really something for you to use and adapt and to base the evidence on. I did want to just raise one other resource that some of you might find interesting if you haven't heard of it before. So the CDC has in the US has a compendium, What Works for Community Dwelling Older Adults. It was updated its 4th edition in 2022. It has 34 single interventions and 16 multifaceted interventions, and provides just some additional reading material and evidence if you're interested in that. It also contains other information around programs like Otago and Life. So from a national perspective, national guidelines perspective moving forward, what do they offer us? So they help us work clearer with shared language and expectations across community, health, allied health, aged care and local government. And I realise that that is a wish in a lot of situations. They can help us work smarter to help us make decisions and to refer that line up with best available evidence. They help us work stronger because when our pathways are aligned, older adults receive more consistent support no matter where they live in Western Australia. And they help us to work flexibly, adapting best practice to the realities of your community, your workforce and your context. And they help us to work together because falls prevention is never, hopefully never, delivered by one professional or one organisation alone. The guidelines don't replace local judgment or context. They simply give us a clearer foundation to build on and a shared way of thinking about how we might support older adults to stay active, stay safe and stay independent. When you complete the evaluation form at the end of tonight's forum, I really encourage you to include in that what information, support or networking opportunities that you will find most valuable moving forward. We use that information to guide events like today. And so ensuring that we're covering the topics that actually mean something to you is really helpful for us in terms of what we're framing. Stay on Your Feet is funded by the WA Department of Health to provide that ongoing training. And so we're always looking for ideas around the events and activities that we can deliver. Thanks. Oh, questions? No? I'm around if anyone wants to ask a question later.
Thank you, Susan. We'll move on to our next speakers for tonight, Faye and Mandy from Osborne Park Hospital. So Faye Baker is an acting senior occupational therapist who specialises in geriatric home visiting, falls prevention and dementia care. Faye graduated from Curtin University in 2016 and has over 9 years of clinical experience across residential, hospital and community settings. Faye is currently working in the Rails team at Osborne Park Hospital, which is a rapid response service for geriatric patients living in the community who are at risk of admission to hospital. And Mandy Peacock is an occupational therapist with 6 years of clinical experience across inpatient services and community home visits. Mandy's currently working at Osborne Park Hospital in the Falls Clinic Service, which is an area she's passionate about. Mandy previously worked at Joondalup Health Campus for 4 years prior to moving to Osborne Park Hospital. So welcome, Faye and Mandy. Oh, what have I done? Whoops. Yep.
Okay. So thanks, Joe. So yeah, my name's Faye and this is Mandy. And today we're going to be talking about the best practice and recommendations for home safety from the Falls guidelines. So just to briefly give you an overview of what we're going to talk about tonight. So we're going to touch on some of the key recommendations within the guidelines and what that means in relation to our home safety visiting assessment. So we're also going to look at some of the multifaceted interventions that are mentioned in the guidelines and what that looks like in the context of the home safety assessment that we're completing. We'll also be touching at the end on a case study. So we might be a little bit ambitious having 2 speakers in 15 minutes. We'll give it our best shot. Okay, so I also just wanted to draw everyone's attention to this report, really, particularly those who are sustaining an injurious fall and then are ending up in hospital. So if you haven't had a look at this report, I would really encourage you to do so. Sorry. Okay, and with this, I really just wanted to highlight the fact that falls prevention is a growing area as we have an aging population. You know, I don't think this is news to any of us, but it really does highlight the importance of those falls prevention programs that we do have in the community. And here it's just drawing from that same report released by Injury Matters. I just wanted to pull some of this data because I think it's really interesting that we can see here, so the place of occurrence for majority of our older adults, you can see is the home. And within the home, the key areas are bathrooms, bedrooms, and outdoor areas. So for those working in community, I don't think that's a surprise. And this on the right-hand side is showing the sorts of is that a person might be in at the top of a falling level, so such as slipping, tripping, stumbling is a key. So I think it just really highlights the importance of evaluating our patients in their home environments as part of a targeted fall safety prevention program, and the key role that OTs do play as part of the multidisciplinary team. Okay, so what we really took from the key recommendations from the Falls guidelines, which Suzanne briefly touched on before, but is the importance of risk screening and conducting more comprehensive assessments for those patients at higher risk. That's something I'm going to touch on a little bit later. It also talks about the importance of multifactorial interventions. So we know that falls by nature are multifactorial. They're often different factors that a person might have that puts them at risk. And so it's really important that we are addressing those individual factors as part of a comprehensive program. And so as part of this is where our home safety assessment comes into it, that if the home environment is something that a person has identified as putting them at risk of falls, that we're looking at evaluating that. It speaks of the importance of making sure the program is tailored and that we're working in collaboration with our patients to ensure that they are involved in the process of planning that. It talks about the importance of multidisciplinary teams, so the allied health members working in collaboration with patients' GPs in the community. And also the importance of education and training. So making sure that we are educating our patients around their individual risk factors and the ways that they can, help to minimise the impact of that risk. So how do we determine who requires an occupational therapy home safety assessment? And that's where we look at our risk stratification algorithm. So this was something that was highlighted in the guidelines, and it's basically a matrix that can help us make decisions and guide our risk screening for patients. Okay, so we can see that for all patients, we should be conducting a risk screen. And then for those that are identified as at higher risk, we should be looking at a more targeted, comprehensive assessment. So what it identifies is that all patients over the age of 65 should be evaluated at least once per year, either by their GPs or by allied health members involved. So patients who have fallen at least once in the past year or who perform poorly on the risk screening questions do need to have a further assessment. And so we have developed what's called the ACDC of falls, which is an easy way to be able to remember these screening falls. So A stands for any falls, making sure that we're counting near misses. Does the person have decreased balance, strength, and deconditioning? And do they have a concern or a fear of falls? So if they answer yes to any of these questions, then that's where we need to be looking at that more comprehensive assessment. Okay, so in the guidelines, I know Suzanne already touched on sort of the low to medium risk patients, but really what I wanted to highlight here is that for our higher risk patients, those are the ones that we're looking at more of the multifaceted interventions. And that includes things such as our exercise programs, our home safety assessment, things such as vitamin D supplementation, cataract surgery, referrals to podiatry, that sort of thing. And the guidelines specifically state that those patients that do require a home safety assessment are those that have a severe visual impairment, who have fallen in the past year, who require help with everyday activities, who have a mobility impairment or use a mobility aid, and those who have recently been discharged from hospital. Okay, so if there's any OTs in the room, this might look familiar, but as OTs, we look at the PEO model. So this is the person, the environment, and the occupations. So what I really wanted to show is just some of the range of factors that we look at for our patients within the home environment, and to show that when we're going out to do a home safety assessment, we're not just looking at the environment, we're looking at the interaction of these factors. So what does the person, what occupations and routines does the person perform? What are their intrinsic falls risk factors, and how does that interact with the environment? So when we're looking at assessing occupation in the home environment, we want to avoid looking at a cookie cutter approach. So making sure that we're considering that person's unique factors that influence their falls risk. We want to be vigilant in assessing, so making sure we're conducting a comprehensive assessment, and we also want to look at 24/7 function. So, for example, if we're looking at our patients that, are on Parkinson's meds, we want to be looking at what their function looks like during both on and off periods. If it's someone that is experiencing falls at nighttime, getting to the toilet, can we consider what their mobility might look like once they've been in bed for a couple of hours? It's important to observe function in the environment, and making sure as well that we're considering cognitive function, which my colleague Mandy is going to talk about next. Okay, so I'll hand you over to Mandy. She's going to talk about some of the multifaceted interventions and how we can look at those and incorporate them into our occupational therapy home visit.
Thank you, Faye. One key recommendation is that patients with visual deficit need to have a home safety assessment. Visual impairment can disrupt our balance, our gait, hazard identification, and depth perception. OT assessment goes beyond just evaluating the use of visual aids, such as multifocal glasses. It also includes things such as evaluating overhead lighting, considering glare, looking at contrast on pathways and step edges, and observing for clutter, and modifying these factors to reduce the falls, such as incorporating task lighting or use of aids such as magnifying glasses, providing education regarding cataract surgery, and identifying need for onwards referral to appropriate professionals. OT play a unique role with regards to medication compliance as part of the safety assessment. OT thoroughly reviews medication through detailed breakdown of all medications consumed, times, dosages, and compliance. It is of particular concern patients who are at risk of polypharmacy. OT recommends a thorough investigation of all medications, particularly reviewing centrally acting medications and other high-risk falls risk medications. As above, it is recommended that patients seek GP and pharmacy reviews, i.e. yearly, after a fall, initiation of new medications, or after an increased dosage of medication. Within the OT home assessment, it is important to screen for any foot problems and to assess footwear as part of an individualised, multifactorial intervention for preventing falls. If any foot problems are identified, it is important to refer to podiatry or for GP to review. It is important to provide education on appropriate footwear options and discuss falls risk related to patients' chosen style of footwear, i.e. wearing socks, wearing no shoes, and also encouraging the use of orthotics and foot splints. It is important to identify symptoms as listed above to determine a patient's risk within their performance of completing ADLs and IADLs. Consideration of appropriate interventions such as equipment, task modification, and education. As per point 2, in regards to dizziness and vertigo, it is important to thoroughly assess and determine potential causes of these symptoms, i.e., is there a postural hypotension element? Conduction of lying and standing blood pressures further supports medical investigations and treatments. Conducting this education in the context of the home, consider daily exposure to sunlight, dietary intake with regards to calcium, also screening for nutritional intake and referring to dietetics if required. It is recommended monitoring of bone mineral density scans, and in the event that none has been completed, encouraging patients to liaise with their GPs regarding same. Cognition is strongly highlighted in these guidelines. As we know, the level of cognition is a risk factor for falls. Cognitive processes such as attention, executive functioning, visual spatial processing are crucial for safe mobility. In the Falls Clinic at Osborne Park Hospital, we commonly assess patients with difficulty with dual tasking, those with slowed processing speed, poor hazard identification, difficulty recalling safety strategies, and reduced insight into their own unique falls risk factors. The Australian Falls Guidelines link nicely with the Dementia Care Guidelines for enabling safe environments. Considering timing of home modifications if cognitive diagnosis is degenerative, so that persons can familiarise themselves with changes early, which may impact falls in the future. Later stages of dementia, including new aids and equipment, may not be suitable. These guidelines highlight the importance of engaging key support within this cohort to reinforce and increase compliance with recommendations. As part of what Faye was discussing earlier regarding the ACDC risk screening, concern of falls is one of the 3 key questions that we ask the sensitivity of our screen and risk assessment. As shown in the above diagram, a person who has fallen or who has had near misses, or those who have concerns regarding their mobility is at risk of entering this cycle. This is a key opportunity to provide falls education to reduce risk of further falls. As part of a comprehensive fall safety home assessment, establishing a post-fall emergency response plan is vital for patient safety and increasing patient confidence. It is important to consider that personal emergency alarms are not appropriate for everyone. as highlighted in recent research in occupational therapy. And that is why we need to consider a person's individual circumstances, preferences, and need to promote compliance. Providing education regarding post-fall health advice is important for families and patients to be aware of potential side effects with fall and head strike and the lag of this, i.e. may not be immediate post-fall. OT strongly recommends for patients to seek urgent medical review with any fall with head strike, particularly those prescribed with anticoagulants. It is important to review patients post-fall as community home allied health workers where practicable, to tweak interventions to address new and changing risk factors.
Okay. How are we going in terms of timing? We okay? Yep.
Yeah.
Okay, so we've got a bit of a case study just to show really what we in the Falls Clinic would do, looking at a person in their home who has been identified as having a fall. So I'll give you just a couple of seconds to read through it. Okay, so if we're looking at our ACDC questions, we can identify quite quickly that this patient is at risk of falls, or further falls, I should say. So are there any falls? Yes. We can also include near misses. She's had 3 near misses in the last 6 months. And in terms of reduced balance, we can identify that as well as concern regarding falls. So we would then do more of a comprehensive risk screen to identify some of those multifactorial risk factors. So looking at the case study, we can identify that the patient lives alone. So this is where we'd be looking at that sort of emergency risk plan, because we know that people that live alone are at risk of a long lie. We would then be looking at the nocturia. So the fall was sustained at night. So we'd be considering things like, do we need onward referral to a GP or a doctor to look at management of nocturia in the night, or do we need to be providing some education around non-pharmacological interventions? So things like limiting fluid intake in the evening, caffeine intake. We can see that there was concern regarding falls. So we would look at providing education tailored to the person, either in the home or including them in something like a falls education program. So at the hospital, Mandy runs our falls education group. We would look at the functional deterioration. So we would look at her function in PADLs and IADLs within the home environment. And we might consider referring the patient to a physiotherapist if balance and mobility were identified as a risk factor. We can see that the daughter is assisting with some of those domestic tasks, so we might provide education around accessing services through the My Aged Care system so that we know that the patient is well supported in the home. We can see that there's not been an OT home visit, so we'd be looking at completion of a comprehensive home assessment of a person in their home environment, performing the activities that they're doing. Again, being vigilant, making sure we're getting them to show us, getting in and out of the shower, on and off the toilet, all of those things. We would investigate the 3 near misses, and identify what contributing factors might have been involved. And we would also conduct a thorough review of medications and past medical history. So we can see that the patient has hypertension, so potentially they may be on antihypertensive medications. And if that were the case, we might refer them for a medical review. We can see that they're type 2 diabetic. So how are they managing that? Are we looking potentially at the person having mismanaged or poorly managed diabetes that might be contributing to their falls risk? We also can see that the patient has depression. So again, there could be anti-anxiety or depressive medications. Osteoarthritis, does the person have pain? And looking at vitamin D deficiency, as Mandy said earlier, we might be looking for a bone mineral density scan and referring the patient onwards for that to the correct professional. The patient at the end has also noted that eyesight is an issue. So we'd be looking at things such as lighting, overhead lighting in the home, removal of trip hazards. We can see that the person has a pair of multifocal glasses, which are not recommended for those patients at risk of falls. So we'd be providing education around that. And they also haven't had a visual test in the last 5 years. So we'd really be encouraging and recommending that they seek that through a appropriate professional. Okay, we've come to the end. Any questions? Sure. Oh.
I get the feeling it's not about older people who are highly active and still involved in activity risks. These are people we ought to encourage to be active and involved. What is the likelihood of these people falling and consequently moving from active to less active and running on?
Oh, okay. So I guess what that person's talking about is in terms of those patients that do fall and then looking at the sort of flow on effect, which if we go back to the cycle, the concern regarding falls cycle, we can see that patients are at risk of having a fall and therefore do then tend to become more inactive. So this is really where our interventions around education are really important, engaging them in an exercise program as well to promote confidence through that activity. We'd also be addressing sort of the, the risk factors in the home to help the person feel more confident with that. Does that answer the question? No? Okay. Anyone in the room? No? Yeah.
Do you encounter much evidence around use of telehealth?
Oh, not within the guidelines as far as I'm aware. They don't specifically touch on that. So yeah, I'm not sure, sorry. All right, thank you.
Thank you so much, Faye and Mandy. Well, we'll move on to our next speaker for tonight, Professor Anne-Marie Hill. Professor Anne-Marie Hill is a senior Principal Research Fellow in the School of Health and Clinical Sciences and WA Centre for Health and Ageing at the University of WA. Her research interests are in improving older people's health and wellbeing. Professor Hill has held 2 NHMRC, that's a tongue twister, investigator grants focusing on falls prevention. She's obtained over 15 million of funds in research and has over 190 publications with over 110 articles on falls prevention. Very impressive. She's a fellow of the Australian College of Physiotherapists, awarded by the Australian Physiotherapy Association. Professor Hill has led large clinical trials in hospital, community and residential care settings, and collaborates with Aboriginal and Torres Strait Islander researchers and communities, focusing on healthy ageing for Aboriginal people in Western Australia. Welcome, Anne-Marie.
To press that on. Hello everyone, and hello everyone online. And I will like to start with an acknowledgement to country and say Kaya Wandju Noongar Budja, and acknowledge we're meeting on the lands of the Whadjuk people of the Noongar Nation, and what a privilege it is to be standing in Boorloo, Perth, and paying our respects to country. And particularly like to thank my colleague, Dr. Margaret Gidgep, for the loan of her beautiful artwork to symbolise our country here. Now, we know that falls happen regularly, frequently, too frequently, and you've seen the Wonderful Injury Matters report. What I think is important for osteoporosis is to think of that intersection So we know that 1.2 million people in Australia have osteoporosis. So when we combine somebody with osteoporosis and we combine the risk of falls, we have somebody who's at serious risk of injury, because when they fall, their bone health is such that there's going to be a strong possibility that a bone could be broken. So it's really important as health professionals and as consumers to be aware that we need to work hard. If osteoporosis has already been diagnosed, we need to suspect osteoporosis if we think that is a factor that we need to look at. In keeping with the falls prevention guidelines, the osteoporosis guidelines are really up to date and very good. And if you have a client, multiple clients, or work with people with osteoporosis, I'd highly recommend that you keep these guidelines in your department and that you use them regularly, because there's been much research on osteoporosis and there's very good advice. And the osteoporosis guidelines contain a number of algorithms and flow charts that help you to understand osteoporosis. But I'm going to say quite early, and I'll come back to this at the end, hoping that I run to time, that it is really important to keep in your vicinity and ready to give to your consumers or help them to access via online the resources that are available for consumers on osteoporosis, in the same way that it is so important to direct all of your clients to the resources on the Stay on Your Feet website about falls prevention. Because if you don't give your clients that information, you are leaving them to grope blindly in the dark when they're not with you, and you are only with them for an extremely brief period, and you haven't a roadmap to follow. One of the advantages of the osteoporosis website and the Stay on Your Feet website is that the resources have been developed, redeveloped, modified many times to hit a large number of older people very appropriately. They're not always perfect and they'll always need some tailoring by you, but they've been designed to fit large numbers of older people. They nearly always cover people who have limited health literacy, and they cover often a wide range of cultural backgrounds. So really important to have those guidelines for the people that you're seeing. And again, if you have people with osteoporosis, if you go to the arthritis online guides, you will see there are fantastic resources for people living with arthritis. Remember that it's the 95% of the time the person isn't with you that you want them to be looking at what they can do to empower themselves to live with their osteoporosis, their arthritis. How are they going to stay healthy and prevent any future falls? They can't remember your short information you can give in a session. So this is where they need those follow-up materials. One of the things I want to talk about is thinking about a case study is if we just think of that person in red or blue as being somebody with osteoporosis, it's really important to not throw the baby out with the bathwater, as the old saying goes. Remember that all older people need to be active. So that should always be the cornerstone of your interaction with an older person. Everybody should be active, no matter what age, no matter what sort of chronic disease they have, whether they're frail and housebound, whether they're fit and in the community, whether they're in a hospital, unless they're, completely contraindicated that they get out of bed. Everybody should be being active. So that's your easy principle. With every patient I see, that will be one cornerstone of my treatment. Now then, what about for preventing falls? How does that fit with osteoporosis? Well, all older adults should be working to healthily do activities and actions that prevent falls. So again, Both those two key guidelines apply to your person with osteoporosis before you ever get out your osteoporosis specific resources. Then as you drill down a bit further, now you've got that subsection of older patients who have got osteoporosis. They've got a diagnosis of osteoporosis. Now you pull out some extra tools and ideas out of your toolkit, having already got the basic ones there, the falls prevention ones are there. You pull out these extra strategies and tips from your toolkit. And finally, in that further subsection, you may have a person with osteoporosis who has a fracture. Now you're going to have to modify in those osteoporosis guidelines, and you're going to have to work hard to think, well, now they've got a fracture, how do I apply the guidelines here? So you've got a one-stop strategy which flows down nicely. It's definitely not, if I have osteoporosis, I won't be active. If I'm preventing osteoporosis, falls doesn't matter. Those things link in a coherent way. So that's, I feel, a really helpful way for us to think about it. As soon as you see an older person, you want to have some alerts in mind with osteoporosis. Firstly, our health professional training tells us that there are certain chronic diseases and medications that increase osteoporosis risk. This used to be, I think, a lesser known thing some 20 years ago, where people with COPD would come along to COPD programs. And they would do, of course, all their good exercise for reducing their breathlessness and increasing their ability to breathe well and do exercise. And then there began to be that concern to go, hey, these people are falling over. And not only that, they're fracturing because, of course, they had COPD, they have COPD, and they're taking medications that thin bones. So if you have a population of people that you already know this is a population where there'll be some increased risk, you're going to be very alert for it very early in that population. Now, for those people who don't directly fall into that category, you're still on the watch for low trauma fractures. So any older person you see who has a fracture that's been sustained from not much activity, not a fall from height, or they report a fracture, maybe they've got a fracture in their foot, or they have what seems to be quite a minor push out onto a wall. They don't even fully fall to the ground, but they fracture their wrist. Immediately you're thinking, this looks suspicious. And if you're the primary person seeing them after their doctor and they haven't, as many older people would now, made it into ED, but they've drifted back out into the community, you're immediately saying to them, let's think about this fracture. We need to get you back to your GP to think about having a DEXA, because we need to think about why this fracture's occurred. Remember also that fractures can occur when you're talking to older people and they're talking of constantly aching backs. We can fall into a trap of thinking, yes, they've got some arthritis. They may say, oh, I've got arthritis, but we need to suspect when people talk about pain that's there often. My foot is very, very sore. I've stopped walking a bit. It's like, is there a low trauma fracture there? Is this a person that might have osteoporosis? Medication adherence. Once you know someone has got osteoporosis, medication adherence is really important. You can see I've just put a quote there for you about, we know that 80% of people over 80 have fractures that are secondary to their osteoporosis. And we know that effective medications can reduce the risk of subsequent fracture, and they've been proven to be very effective. However, people stop taking those medications or are very reluctant to start taking those medications. So becoming an informed health practitioner yourself, so you can encourage a person to do something that's very useful for themselves and to talk to their doctor in depth about taking osteoporosis preventing medications and things that increase their bone density are really important. And people who take medications for bone health will have have significant improvement in their bone health over a short period, and that will stay improved with most medications as long as they keep taking it. We all know that the concern members of the public feel, or consumers, is that there's been noted side effects with those medications, such as atypical fractures. However, we do know that the risk of them is very small and far smaller than the risk of refracturing if you have osteoporosis and you don't take those medications. So when you have people who are at high risk of falls, they have vision problems, they maybe have heart disease that leads to dizziness, even with medication, they have frailty. If they have osteoporosis, it may be very important for you to keep encouraging them to have that discussion. So let's just skim over some of the things that are kind of secondary to our osteoporosis. We start by saying, here's the recommendations for everyone, whether you have osteoporosis or not, whether your client has osteoporosis or not, here's what any older person should be doing. So our osteoporosis treatment is going to cover those particular points. We also know from good research that we've got to give people lots of appropriate exercise for themselves. We know that a balance exercise of standing on one foot could be very easy for nearly all of us here, but could be very challenging for another person who's frail. So our balance, our exercise has to be appropriate. We know that TheraBands could be very easy for some of us sitting here, but could be quite challenging and build strength in somebody who's very frail. So we've got to do things that are appropriate, and we've got to offer choice. Nobody does exercise that they dislike intensely. And we've got some fairly strong research talking about that concept that if you group older people and do large surveys, you find it falls into a room split like we're sitting here tonight. About half of older people will enthusiastically think a group exercise, social interaction, a cup of tea, getting out to their exercise is great. And the other half of the room will think, I don't want to go to those sorts of exercise. I prefer to do my exercise. I'll look at a video online, or I'll do it in the privacy of my own kitchen, and I don't really want to go out and do exercise with other people looking, I might do it wrongly, or whatever reasons people have, they might just not feel very sociable. So we need to make sure the exercise is something that's fun, enjoyable, people can do it, it's challenging. Exercise, including for people with osteoporosis, should always include balance. So that's a fundamental thing for falls prevention. And it's a fundamental thing for osteoporosis because we want people with osteoporosis to reduce their risk of falling because the risk of injury is so high. So we've got to include balance activities. And I'll talk a little bit more about that. And here's where you need your guidelines for osteoporosis to be able to knowledgeably discuss these kind of referral patterns that you need to make, and the recommendations for people with osteoporosis. Do you know that people with osteoporosis need to make sure they are getting a full amount of calcium? If you talk to people about that, they will often say they're getting enough, but if you ask them, actually tell me exactly what you ate for your meals all yesterday and what you ate the day before, and if you jot that down and just explain to them, what you ate yesterday contained 300 milligrams of calcium and you need 1,300. It's quite deceptive how many older people are not calcium replete. So you also need people to understand about vitamin D. If they're not going outside much, they are unlikely to be vitamin D depleted. So those kind of things are very important. And of course, getting onto pharmacology and asking people to visit their GP, and if they've visited their GP, encouraging them to visit a specialist. Now, I'm not going to talk about this in depth because the detail is in the guidelines, but I do just want to emphasize to you that when we talk about osteoporosis, we talk about resistance training, impact training, and balance exercises. So for people who are able to, resistance training is excellent. And we should remember that if a person is frail and at home and are doing nothing, resistance training with TheraBands is going to be able to meet the 1 RM capacity for that person. Again, with impact, someone may not be able to do skipping, but there could be impact work they could do at home, foot stomping, getting up on a low bench, up and down, things like that. So we can flexibly try to build some bone strengthening along with the other activity they're doing. For people that are very willing to go to a gym, they can do something that's even more intensive. And again, don't forget our balance exercise. Notice that this is a lovely infographic you can keep in your own practice, which just gives you that nice picture for older people of what you can talk to them about. I really like that. I think it's a clear, simple thing that can be used to just give an older person the quick visual picture. I've said this a little already, but for people who are frail, including people with osteoporosis, remember that one of the best interventions for frailty is physical exercise and mobility training. It's one of the best interventions to improve, reduce the effects of frailty and to try to reverse some of the effects of frailty. So don't exclude people with osteoporosis who are frail. Work on getting them a suitable program. And finally, for people with osteoporosis, I'm just flipping back to our FORS guidelines, it's really important that they also receive this information very strongly, making sure that we give them early proactive ways to reduce their risk of falls, especially if they haven't been exercising and we're trying to build up. So for people with osteoporosis, it's going to be very important to avoid using ladders. And again, vision, making sure that we give people these good ideas about how they're going to reduce their risk of falls if they have poor vision. So some of those falls prevention tips, strategies based on the guidelines are really important to bring up early for people with osteoporosis. Now, I'm just wondering how much time I've got. Okay. I just want to talk a little bit about barriers to exercise, because we all know people should be doing exercise, but we know only about 1 in 4 older Australians do exercise. So that includes people with osteoporosis. The key thing for people with osteoporosis is to address the concept of, now I've got osteoporosis, I really can't do exercise, or I'm fearful to go anywhere because they might give me exercise that will cause a fracture, it will hurt my back. And so some of the messages are about giving positive messages. So this is a great thing to talk to people with osteoporosis about. This is an excellent article, which is talking to people about being strong. If you do exercise, it strengthens your bones. Being steady. If you do exercise, balance exercise, you'll get steadier, you won't fall over, so your bones will be at less risk. And finally, being straight. If you have vertebral osteoporosis, any exercise we can give to help you keep that lovely straight posture you've still got is perfect. So giving that positive reason to exercise. If you have osteoporosis, let's keep you strong, steady and straight. I know that would make me as a person with osteoporosis feel, oh, I can immediately see it seems like I should be doing this, rather than be fearful. Now my bones are weak, I sort of have to tiptoe around with my walking frame. So we don't want people to do that. And finally, I'm just going to bring up tailoring your discussion and making sure that you give this kind of effect. You know, you want people to exercise, you want people to take medications if they have osteoporosis often. You'd like people to be seeing other people, like you want people to feel confident. I will get an occupational therapist. I'll proactively install a couple of extra rails because I know I do have some problems in the shower. I'm, as you know, some of you will know, very interested in education, and it's been a large part of what I do. And one of the things I think with education, you notice the new falls guidelines simply say, please give people education if they've had falls. I have a significant issue with that, and I'll tell you my issue. If I say give people balance exercise, someone like Tony, if I asked Tony to give an exercise prescription to any one of us in the room, he could examine our balance and he would give just the right exercise prescription. But what do a lot of us know about education? Because a lot of education is not evidence-based. Some of it leaves older people with actually wrong information, doesn't include the right information, or doesn't include it to be directed in a way that builds self-efficacy. So education is an area I think we need to delve into, because it's important that we give people the information. My education knowledge is more limited to hospital falls education. Recently, our colleagues with Dr. Joanne Hang there have done some very good work with education for people who are frail and at home, and have had some wonderful results about providing those people with tailored education for frail older people at home. So I'm just going to suggest to you that as a start, if you asked me, well, Anne-Marie, what could I do to do good education? I'd say, well, the first tick box is you must give the older client, you see, every older client resources. That would be a fundamental. You would never expect any of your own children to go to school with no textbooks, no paper, no handout. But there are many patients we seem to remember to manage their whole health condition by a few people talking to them. So I'm going to say that's my first fundamental tip for education. And of course, thank you to all our consumers who are the people who've helped me so much with this education. And I'm happy to take questions if there's a minute or at the end.
Thanks, Anne-Marie Hill. I really love that positive framing, very important. We'll move on to our next speaker now, Tony Petter. So Tony is a physiotherapist who has been employed in a dedicated falls prevention role since 2000, working across the Charles Gardner Hospital and more recently Osborne Park Hospital. During this time, he's worked across all settings, including inpatients and residential care, though his main focus is in the community setting, working with high-risk frail fallers. Tony has a keen interest in teaching and training, having worked for over 10 years at the Curtin School of Physiotherapy, whilst also delivering countless training sessions for staff in the community and residential care setting. He has collaborated in research for falls prevention initiatives in the ED setting and worked with colleagues at Curtin University in the use of virtual reality simulation as a teaching modality for falls and geriatric syndromes. Tony is keen to ensure those working in the health and related sectors have a strong focus towards falls prevention, particularly as he is approaching the age of increased risk.
Hello, everybody. So the talks have kind of all blended in together, and mine probably overlaps with what's already been presented a little bit. I'm one of those people, when Suzanne actually pulled out the green box, I've got actually 2 or 3 of those. Anne's got some. And we're actually hoping that they're going to increase in value and stuff, because, you know, we might be able to retire on it. But I've got about 3 or 4 of them that I've hidden away for all these years, so I'm going to pull them out. Anyway, let's move on. So in terms of the Australian guidelines, there was 4 key recommendations around 1A evidence around exercise, as you can see there. Anne mentioned a little bit about the ongoing exercise in terms of for all older adults. And I suppose that's really where I want to start, is this really is fundamental. What we hope for all older adults, or before they even become older adults, is that they've already had a lifelong approach to physical activity. I always say that the benefits, or to really prevent falls and injury from an osteoporosis perspective, we need to think about our children and what they're doing at that age, because bone health, it really only increases until we get to our mid-20s. If we never achieve really good peak bone mass, it doesn't matter what we do after that, we're always trying to catch up. So it's our young people who really need to be active, and then hopefully we bring those lifelong habits through as we get older. So by the time we do get to 65 and we become older adults, we've got well-entrained physical activity kind of like principles and habits that we continue to maintain. For many of our older clients, but they're not used to exercising, so we need to get them engaged as much as we can in doing some kind of activity. And sometimes it's often very unstructured. They're just moving, doing something. Don't stay in the chair as much. Try to go out for a little walk. maybe we can get you involved in some kind of exercises that will be more specific for you. But we've got well-established national physical activity guidelines. These are actually almost international, these guidelines from the World Health Organization. But as Anne mentioned, they focus on an aerobic or endurance component. But most importantly, from fall prevention, what's really vital here is that there's a strength and balance and coordination component. And what we need to think about is that our older adults are not just maybe potentially at risk of falls. They might have cardiovascular disease, they might have diabetes, they might have depression. They've often got multiple comorbidities, even if they haven't fallen, in which physical activity and exercise has been shown to be beneficial. So well-structured programs which address multiple conditions can be really beneficial. We can't be too naive to think, as much as we love falls and we really want to prevent falls, we can't just be thinking just from a falls focus when we want people to be having a comprehensive program that covers multiple conditions, because people can't do an exercise program for cardiovascular disease, one for diabetes and one for falls prevention. We need to make sure we're prescribing appropriately so they've got a well-balanced program. So screening assessment has been discussed. Screening is basically case finding. Who in this room is an older adult and is at risk of falls? Okay, whereas falls risk assessment is the more detailed evaluation of that client, trying to tease out what are those specific risk factors that make that person at risk that we can then target and address through some of the interventions that have been highlighted in the guidelines. There's multiple screening tools, okay, and we don't have time tonight to be going into it. We could be talking a whole seminar about screening and assessment. So the one in the middle, which is the fantastic Stay on Your Feet checklist, okay? The great thing about this is that some older clients will actually come to us with this tool and they've actually self-evaluated. So they come having evaluated their own risk and they're proactive in wanting to do it. The two tools on the outside are two more common tools which are used professionally around Australia. There's the PropCom screen and there's the Quick screen, which is used fairly widely in New South Wales. They're slightly different in terms of the questions that there as well. But what is most common to all three of these screening tools is, have you had a fall in the last 12 months? Okay, so the simplest question that we can ask is often the most important one, because that will open up a whole world in terms of where we go in terms of working out what we need to do with our clients. So as we've alluded to, we have three risk kind of like categories within the Australian guidelines. We've got no risk or less than 1 fall per year, 1+ fall, or 2+ falls. The reality is, in practice, is that when you've had 1+ falls and 2+ falls, there's very little difference between those clients, and it's very hard to clearly delineate and say, well, you're a 1+er and you're a 2+er. It doesn't really work like that in practice, but it can help us in a way in terms of targeting interventions, because we know resources are a little bit more limited. Don't forget that many clients will present to you as a health practitioner or to a health service, to an ED or whatever, with a fall. We don't need to screen these patients anymore, okay? We need to start evaluating them in a little bit more detail to work out, you know, are they going to be able to go down a single intervention, maybe like an exercise program, or do they need a more multifactorial intervention? So the guidelines recommend, as we mentioned before, all of these clients at risk benefit from ongoing exercise. The no fallers, or the very low risk, so less than 1 a year, they benefit from a regular exercise program that targets strength and balance, particularly delivered in the community or at home, okay? But they also benefit from education. We've already got beautiful resources through the Stay on Your Feet program, but we don't just have hard resources. They run peer education groups. They run seminars for people in the community. This is what this population needs to be getting involved in, okay? There might be things that are run at local community recreation centres where they're organising programs. This is what we want this population to be exposed to. The physical activity guidelines forms the basis for many of these programs. Many of these clients don't necessarily need to specifically see a physio or exercise physiologist to have a tailored program, but they need a good structured exercise program that addresses their endurance, flexibility, muscle strength and balance. This population, when we start to having had one or multiple falls, this is where screening becomes a little bit more complicated. We need to start looking at maybe assessing their balance in a bit more detail. So the screening tool, so in the World Screening Guidelines, they recommend that we do some kind of evaluation of these people who are single fallers. So how we do that, they report whether we use a measure of walking speed, such as a gait velocity or timed up and go. Now, depending on who you are and what your scope is, you might not necessarily feel comfortable with that. But if you have identified somebody who's at increased risk, then it's kind of like the onus is on you to say, oh, look, well, I need to get you to the physio or the exercise physiologist who they can look at your balance in a bit more detail. Okay. But once we've worked out if they are at increased risk because there is a balance or gait disturbance, then these patients here, if they're fairly clear in terms of other factors and stuff, they do benefit again from a tailored exercise program, one which addresses their specific impairments around muscle strength, balance, coordination. Okay, so it's tailored to their specific needs in terms of their balance impairment. So we need practitioners who are skilled in evaluating balance and muscle strength. These clients also benefit from education. Faye gave the example of a falls education group that we run at Aussie Park. Certainly, any exposure to education programs and stuff, which has clients to think about their risks, think about their own environment and stuff, can be really beneficial. And these clients here, they're often still very active in the community. So it's not just about falls at home, but it's thinking about how they mobilise and interact in the community. This last group, they need a more detailed assessment. This can occur in primary care through a GP or their practice nurse, but it may also involve other practitioners involved in a team care plan. The falls clinics, which are located metro-wide, we really only see a very small proportion of people. I mean, in our clinic, I think we see probably maybe 1,000 people a year, but that's still little numbers compared to the population of people in West Australia who fall. So we need primary care and other skilled practitioners such as yourself to be conducting these more detailed assessments for that more higher risk population. There is evidence for exercise in this group, but typically they are a bit more complex, they're a bit frailer. So we often they're a bit more difficult to prescribe to, but they follow a similar, the key recommendations around exercise prescription for this group follow the very similar to those with the 1+4, which we're going to go through in a minute. That's what the World Falls Guideline looks like. So the kind of like the algorithms, they're very similar in a way. They just use slightly different terminology. I would recommend, just as Suzanne recommended, the Australian website to get detailed booklets and information on screening tools and the guidelines. The World Falls Guidelines have also got multiple great appendices where you can access fantastic information. So, as people age, we can acquire risk factors which are sensitive to exercise. So these risk factors which contribute to us falling can be beneficial and prevented or controlled by exercise. It's not just, however, the physical risk factors. It's not just weakness or a problem with our balance. But often it's the decision-making that we implement when we're actually navigating through an environment. So that executive function. How do we plan to walk across the road there? Are we going to go where there's actually a proper flat bit which goes down to road level, or are we going to step down the high curb when we're actually a little bit wobbly? So what decisions do we make? So there is some emerging evidence around using exercise to try to help in that terms of that executive functioning. So around, I think they call it gait adaptability training. It's where they really get older adults to practice walking within challenging environments and undertaking specific tasks, which can help to maybe possibly improve decision making. So targeted exercises are more than just standing on one leg. People don't just fall when they're standing still. Typically, people are moving. And I do have, it is a bugbear of mine that if we are going to get people to stand on one leg, that we don't just get them to stand lazily on one leg, drop their hip and not control. If they're going to do an exercise, get them to do it properly. Get them to think about what's actually happening when they're standing on one leg. Just the one thing. So often most of the time, people will fall when they're moving. They're changing posture. What is their stability like when they move from a sitting to a standing position, or when they go from standing on one level to another level as they're descending one step or a curb? Or how do they control their movement, stepping over a shower hop, for instance? So we need to think about their balance from that perspective. How is it functionally? A couple of years ago, I was at the petrol station and, you know, I got distracted by a noise. So I turned around and I kept walking. All I remember was this. I don't even remember hitting anything. And I remember my hand kind of like striking the floor. Distraction. My attention was completely diverted. Didn't see the little low parking bollard, which I completely kind of like missed. So one of the things that we all do is we often are not thinking just about the task at hand. We've got multiple things on our mind. You know, we're a busy person, we're out doing shopping or we're doing some kind of activity. So falls often occur in the context of multitasking. Some tasks may be more difficult and represent more of a challenge to older adults, so we need to make sure that our exercise program think about some of the tasks that the older client might report to us, which has become more challenging. And what about reacting to prevent a fall? So the final pathway for preventing falls and possibly not having an injurious injury or an injurious fracture, for instance, is making sure that we've got appropriate balance reactions in place when we exceed our stability limits. In some instances, this is impossible. It doesn't matter really how good our balance is, we will exceed. But even for this lady here, she's actually implemented a protective response. She may or may not end up with a Colles fracture, but she has saved, and that upper limb response is to protect the head from injury. So it's important when we're doing our exercises and also when we're assessing our patients that we teach them about how balance works, how balance reacts, and that pathway, and you know, how we move from being able to control our balance to when we actually need to react and take a step or grip for something. And finally, from thinking about what we're doing, is we need to think about functional tasks. So all of these components about how people fall with regards to their movement, we need to bring it right back to what's important for them. Okay? Mr. Smith likes to get onto the floor to do a little bit of yoga or something, but you know, he needs to be able to maintain his joint mobility as well to be able to get on the floor. So one of the things we often don't think about as much is often not an emphasis on flexibility and mobility of joints. People can't adapt postures if they can't move through range of movement. They might not be able to do a sideways crossover step to prevent them from falling sideways if they can't get their left leg over their right when they lose their balance. So never forget about the importance of joint mobility and flexibility as part of a well-balanced program. So excellent article that came out this year from Anne Tiedemann from the New South Wales group, which did an excellent summary around the key issues around exercise prescription for falls. My eyesight is really quite bad. So some of the key things are, we need to be looking at 3 to 4 hours at least per week of activity, focused on the components of exercise that we use for strength and balance. The reality is we want people to be able to sustain their exercise over the course of at least 12 weeks. And hopefully by then, if they haven't been a regular exercise, they've developed a well-entrained habit that enables them to sustain some kind of structured exercise moving forwards, okay, when you're possibly not involved. It needs to be individualized when people are at risk, okay? So it needs to target their specific impairments that we identify from their assessment. High balance challenge, that's pretty obvious. We need to make sure that it's stressing them right at the point where they're having to work quite hard. One of the hardest things that we have as practitioners is actually getting a patient to work at a really hard point and them actually saying, oh, is it really trying to work out how hard is a balance exercise? I can go for a run and I'm pretty unfit when it comes to running, and I'll run down the road and I know I've worked hard and I've only run about 200 meters. For a balance exercise, it's often harder to work that out. But think of the subtle signs you might see with the patient. They won't let go of the bench when you've given them an exercise. They might start to hold their breath, or they start to move their arms really wildly, or they'll suddenly widen their base of support because you've started them in the wrong position. Okay, so think about how you challenge their balance and try to keep it at that point where they're having to work really hard, but not so hard that it puts them off. Functional strengthening, so getting them to move during the activities that they need to do. Incorporating a range of exercises that incorporate stationary postures, but also movement and balance reactions. So when we exceed our stability limits, we need to make exercises harder. So don't just do a set and forget and never see them again. Okay, but you need to set, let them go away if they're doing their program, or if they're doing it in the gym, regularly review their program when they're coming in. Okay, how can we just tweak that little exercise again? Okay, well, now that you're standing on one leg, start moving your leg out to the side or moving your arms, or you catch this ball. So you need to be constantly trying to challenge the person to try to get them to actually be improving their balance. Multisensory, think about how balance works. Eyes, ears, somatosensory inputs, organised by the brain with an output. We need to make sure that we incorporate different inputs in terms of challenges. We need to incorporate head turning, eye movements, moving up and down vertically, which can assist in terms of stimulating the vestibular system. So we're using multiple senses. Dual tasking, okay, as we mentioned before, both whether it's a cognitive challenge or a manual challenge, they're actually doing something. So often think about the person carrying the shopping over the threshold. They're needing to do a motor task, they need to open the door, they need to step over the threshold, keep their balance. Programs can be delivered either via home program or group exercise, and Tai Chi is an excellent activity because it's dynamic, it's controlled. But we often need to think probably it's for those clients who are at lower to evolving risk of falls rather than your really high risk clients. This is just a one slide from Ann Tiedeman's article. It's got lots of ideas around exercise, which are really good if you struggle with ideas, like I sometimes do. But key things about trying to improve or to progress exercise. Key principles: reduce base of support, make it more dynamic, add resistance, reduce sensory inputs. So maybe going from eyes open to eyes closed, or doing things like that. Dual task complexity. Maybe it's not just a manual task, but then you're actually talking to them while you're doing it, or giving them decisions to navigate in an obstacle course. And volitional to reactive stepping. That's where we're practicing reactive exercises and moving from a person initiating it when they're not at their limit of stability to then having to actually react. And in practice, this is actually pretty difficult to do. There's been some certainly studies which have looked at treadmill training with support where you can do this a little bit more, and you can stop the treadmill at a particular time and somebody will need to take a step. But most of us don't have exposure to that equipment. And also we need to think about how we could do that in a practical sense with a vast majority of clients. I'll often use this little trick where this is a great couple of exercises that came from the No Falls program many years ago. But I love this. It's about getting people to work at their limit. So knowing where they can get to without actually overbalancing, and learning that that's actually their limit. What happens when you go further than that? You either fall or you take a step. Okay, so we've automatically then educated the client about what happens when you're at that stability limit. Some clients will not have a reaction. Okay, they won't be able to take a protective step. So it might be, well, how do you, when you're reaching for something in the cupboard, what do? Well, that's when you need to maybe change your base of support. So using we need to teach our patients about how balance works, not just give them exercises which helps to improve their balance. Some of our clients will also be going away from us, and we want them to progress their exercises themselves because it might be a few weeks before we get to see them. So they need to know about how balance works. The Life program is really good with this because they really go through that principle of teaching patients how to actually, this is how your balance works. And so people have got ideas as how they can progress their balance when they're not with you. So balance recovery, as we've spoken about, thinking about the main directions. But I will often do this with many of my clients, but you've got to choose your clients carefully, okay? The frailer a client, the more dangerous this is and the more risky it is. Sometimes all you can do is actually get them to do volitional stepping. You can't actually get them to tip over the edge and then step, when they've actually gone over. Sometimes that needs to be self-initiated. I just wanted to make a brief note about walking and falls prevention. Walking is a fantastic activity. Older people love it. The most important thing to think about is that it does not replace what we need to do from a strength and balance component for our falls prevention. Okay, and if people have got osteoporosis, and they've got a falls issue, we need to be very careful about promoting brisk walking, because the margin for error can potentially be very minimal and they might be more prone to having an injury. But from a functional perspective and building endurance, walking is really important. Anne-Marie also so eloquently kind of like described exercise to load bone, but it's around progressive resistance training, high intensity, and then also balance training and impact exercises. I'll let you can follow the resources. So in conclusion, making sure we do falls risk screening to identify people at risk, assessment which allows us to target specific risk factors to address, and knowing that lifelong exercise is important and that we need to get our clients at risk of falls and even not at risk of falls doing specific strength and balance exercises on a lifelong basis. Okay, thanks everybody.
Thank you, Tony. We are running quite a bit behind at the moment, so we're going to have to skip questions for the next couple of presenters. But thank you so much for that, Tony. I'll now introduce our next presenter for tonight, Hannes Holly. Hannes is an experienced exercise professional and PGA golf professional with a strong background in rehabilitation and injury prevention. Since beginning his career in the fitness industry in 2008, Hannes has worked with a wide range of clients, from athletes to individuals recovering from injury, and focusing on restoring function, improving performance, and promoting long-term health. His approach combines exercise science, practical coaching, and a deep understanding of human movement to help clients achieve sustainable results, both in fitness and on the golf course. Welcome.
Thanks everyone for having me. I kind of tie on what the previous presenters just said, that everything will roll into the same kind of subjects of where I'm coming from. I guess where my place is, I run a lot of group classes. A big one we do is through Connect Big Park in Victoria Park. There's a big program. It's a hub where everything is from Tai Chi to chair yoga, Pilates, there is exercise classes. So it's a great way of actually tying it all into one place. So people come, usually my session, the exercise class is followed by yoga, and people then just stay for the next class, or the next day there might be a Tai Chi class after, or Pilates class. So it's a great way for people actually to be able to get the best of everything. So there's a strength program, to have a balance program, to have a mobility program, and that's a good way of actually helping people. They usually wouldn't do it themselves. There's definitely a high social aspect as well. So the hub is created for people to come there, to actually socialize and to exercise, because they wouldn't do it otherwise by themselves. So for exactly like you said before there, we target the people, they're actually coming proactively already. They're looking for that program. We try to get all the people, they don't know about it. And that's obviously when we do programs through, I'm doing currently one in Bassendean, that's through Connected Park as well, where we go out in the community and we just explain over 6 weeks of how programs should be run and why they should do exercises, why it's great to get stronger bones, get more muscle mass, why they need to do it to prevent falls. So in my actual parts of why exercise can prevent falls, what kind of exercise should I do, and where can I join exercise classes. So it's not very much known in the public what to do. So you guys, physios, wherever you go, you see that from a clinical side of point of view. I see them firsthand after they come to me, or best, they never actually see you. So they do everything right, if they never see a physio or never have a fall in first place. And that's what I usually tell people when they start class. It's like, oh, I'm not there yet. I'm not 60 plus yet. So like, well, exactly like you said before, we try to get the people with 30, 40 and then go through the progression and actually never, ever experience a fall in first place. That's the idea. So when we do the exercises, we all know about what to do, what we need to do. That exercise improves bone density. But I like to do two different parts. So I do Nordic walking, if you have heard of pole walking before, coming from Austria, coming from the Alps. That's how I grew up with. And it's a very great way for people also to do a little bit strengthening while they do the walking in general. So there's a bit of technique to it. So if you're interested in, look up Nordic Walking WA, and then you will find me. And then we can talk them through groups. There's also a group run through Connecting Park, but I do 2 walking groups a week. One is more targeted 50 plus. We walk in Kings Park, we walk in South Perth. Every week's a different venue. And then I have a group on Saturdays that's more in the hills. So on loose trails, we actually make sure we go and have a little bit more resistance as we walk. Then my exercises are all the same as we just heard before. It's weight bearing exercises, resistance exercises, balance and posture exercises. Plyometrics are really big on plyometrics, especially for bone density. And I'm not shy giving those kind of exercises to especially people 50, 60 plus. Once again, the ones I see usually on my classes on a weekly basis, they have a base fitness. So I can do slight jumps if they're not comfortable. We can talk about going down the stairs. If you're not how much you're familiar with eccentric training, I run a program that's called Stay Sharp with Professor Ken Osaka from the ECU in Joondalup, and it's all based on eccentric exercises. And there's a lot of background there, a lot of research there on what exercises do. For example, going down the stairs, they have developed a huge amount of exercise equipment where everything goes in reverse. So for example, there's a bicycle, you do eccentric loading and then the machine helps you back up again. So everything is working the opposite direction. So if you look into that, that's very interesting. And then obviously, like I said, the Nordic walking, that's pole walking, but it's not using poles for as a tool of rehab. So we use it actively to push along. It comes from cross-country skiing. So if you've ever seen the movements, and we should really, well, my background is I use it with athletes for summer training and for the winter sport. So we also do roller skiing. So we own skis on wheels. So if you ever see people skiing around in Perth, it's usually people that are involved with me, but that goes up to Olympic level. So we train athletes, they go to the Olympics, especially Aussies. And we have 2 here in Perth. They're already 3 from Norwegian background, but they're actually from Perth and they're actually going to be in 2026 at the Olympic Games in Italy. And they all come here from Perth. They have learned it on the wheels and now they are representing Australia on the big stage. So it's quite interesting. So what I'm doing a lot in my training is we all start with the normal warm-up, dynamic movements. Then we go through a range of motion. Then we focus from the bottom up. So I make it as easy as possible. When people come to me, my classes are with music. They're from the 50s, 60s, 70s. We have the playlist. It gets the people coming. The ones I see in Connected Park, that has been running now for 6 years. And pretty much everyone that has come will continue to come. They come 3 times a week. The classes are full. Every time people have to sign in. There's only 20 people in the room and then it's online as well. And the classes are always booked out. It's because I like to make it fun. I'm not in your position where I have to do it in a clinical way. I can have fun with it. I can play around. And when I saw the key points there, I didn't even realize that I do most of those exercises because purely that's how I structure my program anyway. So I want to engage people. So when you have people, they need your help and they want to continue doing something, then maybe a program that is a class-based program is a great way of doing it. It ties in the same ways. What I mean with a warm-up dynamic movement is we have big room and they all have a chair. So if they need a chair, need to do the exercise on the chair or by holding on to a chair to assist them, they can do that. If they can do it standing, they can do it. It will be similar, just leg swings. It will be slight rotations. We just do a dynamic warm-up. We do it under the music. So we have the same routine we go through. And the same is with joint rolling. We start always from the top down, shoulder rolling, thoracic movements, hip circles. It's very similar to go from top down, and they tick the boxes. So it takes 30 seconds, 45 seconds. And then I do my strength training usually from the bottom up. So it means we start with calf raises, and then work. And that's how I explain it to the people as well. It's like if they think from the bottom up and they know about 2-3 exercises for each muscle group, they would also most likely do that whole. If they hear 2-3 reps 15 times, 2 to 3 kilo dumbbells, it's very difficult if they don't have a picture on how it should work. If I tell them start from the bottom up, we do calf raises. That's the first muscle group you encounter. Then we may have the quads. We do sit to stands, or we do eccentrically just loading slowly into a sit to stand. Then we go for leg raises, get the hip flexors moving, simple exercises. We're sitting on the chair. We do negative crunches on the chair, for example, or all the crunches are actually sitting on the chair, making sure that they can do all those trunk movements. And then we would go up simple with arm movements. My classes are all with weights. So I use weights for all the classes. But if they choose, they can't do movements, then we just work with what we have. And that's the hard part in group classes. I guess I have 20 people in a room and they're all at different stages. So the warm-ups, they can all do the same, but then generally everyone has to choose the weight they want to. But my position is to challenge them. I know they all come in, they take the little 1 kilo weight and they're smiling after the 20th repetition. So I make sure next time they will choose the next weight up. It's hard to control posture when you're in a room with 20 people. So unfortunately, since COVID, now I have an iPad in front of me and everything is actually filmed and zoomed. But on my Wednesday class, for example, it's still a circuit-paced class where I can walk around and then actually assist the people as they go. I do the Strength for Life program through, if you know, for example, that's in rec centers and stuff. I'm one of the mobile providers that can actually go. And most of the classes I run on a daily basis are in assisted living places. I have about 6-7 retirement villages I'm visiting. I'm now starting with Mercy Care, so I will do all the exercise programs through Mercy Care in 2026. They have 6 venues in Perth, and we're going to run all the programs there. And it's all the same way. It's dynamic movements. It's doing, like we said, for example, the clock lunges. I always explain people that in a functional way. They know they shuffle walk. And then I tell them, for example, if they do heel to toe exercises, not just calf raises, but we do heel to toe exercises, that's what they need to do, to explain to them why would they fall. When we do lunges, it's a clock lunge, they learn to fall and they get that reactive way, like Tony just explained before, that when they trip, the body still constantly does what we do when we are kids. When we're jumping around, we're doing our exercises, we know what to do when we actually lose the balance. When we get older, we get sedentary, we don't have that anymore. So my exercise philosophy is, if they keep doing what they always did, they don't even know they need to use it. It's a natural movement that if you lose the balance, it's the step that actually stops and prevents the fall, not reaching out, because usually it's a secondary injury because we're looking for somewhere in the kitchen to stop our fall. But if the first reaction will be the natural reaction for the body to prevent the falls with an easy step to the side, that's something that needs to be trained or retrained. Most likely we had it, and it's just our way of actually getting it back again. And most people, they do lunges in the gym, that is great, but it's a machine that assists. So once again, if you have dumbbells, resistance bands, whatever it may be, it's more dynamic the movement is, it's more strengthening around the joints we create as well. It's not just a machine, and most people know that. And that's a Strength for Life program with a little bit of a problem like that, because we put them in stations and they use fixed machines when we work. Well, my exercises are more with free weights, with more movement involved. And like I said, the main part is having fun. If it's fun, people come back, do the class again. I see my people 3 times a week, and in all the other classes twice a week, every time. So I have them over 6 years or 7 years. Some of them, the oldest class around is since 2010, so that's 15 years now, the same clients. I started with moms, fit moms, pre and postnatal. Don't ask me how I got into there, but that's what I did. And then suddenly progressed. Now it's perimenopausal, pre and menopausal classes. Then we go into the 50 plus, 60 plus exercises. So they all kind of progress, and the people progress the same way. But like you mentioned before, I like it very much, is people need to learn that it's all a pathway. There's a reason why the bones get more brittle. They might not understand that it has to do with perimenopause, lack of estrogen, and all this is tied in. When they learn more information when they're younger, they understand why it's so important to do falls prevention when you get older. It doesn't start when you're 60 plus and you hear about the falls. We all know what happens if you have a fall and the likelihood of recovery when it happens in a high age. But if they understand with 30, 35, 40, why they need to do what they need to do now, and that information is not given. There's lots of talk now with perimenopause, but there's not much information out there. And especially that's why I train with the fit mom classes I do, is give them the information now that they know that that's all tied in their bone health when they get older. Yeah, so it's all tied in the same way. So I guess in my programs, it's the way to get started is to quit talking about it, begin doing it. That's what my philosophy is, because every time I see somebody, it's like, yeah, I got a flyer, I will do it. Or I got a flyer from a physio and nothing ever happens. Yeah. So the problem is, how do we get them to participate? One is obviously the buddy system. There's already somebody in the program and they drag somebody else along. And what I would like to see is that there's more open days. Like I go to retirement village, I stay out there, we go through an exercise program for 3 minutes. We sit on the spot, we run, we punch, we get the music going, and then everyone's saying, oh yeah, I can do that. And as soon as you get that, I can do that, they will do it. But if they just read it, it's very hard to convince them. And then they need somebody that's very good or firsthand, especially a physio, very convincing that that's what they do. But once again, I love the physios because they get a stick man and then it's like 3 of them and 5 of them. And they go home, they put them on the fridge like I do. They always come to my class. They never remember what we did. Yeah. The only reason why it works is because they keep coming to the class. Yeah. Handouts, amazing, but they need to get explained what they need to do at the same time. It has to be practical, and practical stays in your mind if you had something positive you remember with. And that's why I tie the music in, because they all say, oh yeah, I remember that song. And then they forget about what they're doing and they're suddenly moving to, you know, great balls of fire, whatever it might be. But they forget that they did 20 repetitions of something, you know, and that's what the important part is about exercise in general. Good. Come to the end of it. So exercise obviously improves your life quality. Everyone knows that. But the biggest thing I always tell them is it keeps you independent for longer. So if you are with Connect Park, they have assisted living as part of it. So they have apartments they look after. But the idea is that people are independent all the time. So we don't want them to get to the stage where they need the help. They need to exercise so they can do everything themselves. It's about them being able to get a cuppa out of the highest part of the shelf. It's about them to being able to still clean the floor. It's them to be doing practical things like opening a milk canister. It's so hard for older people to even open them now and then. And if they learn exercises like we use the weights and we do the roll up, roll down, they understand. And I tell them this is to make your wrist stronger so you're actually able. And they're like, oh, yeah, that makes sense. And then they do the exercise because they realize it will help them in their real life if they do something. Good. The social life is one thing. Like I mentioned, not everyone's cup of tea is to do group sessions. But if they walk, they might go out a little bit more. I always tell them when, oh, I'm walking my dog. I say, yeah, that's the exercise for the dog. And then you do your exercise. And if you go to a park, go to the back of the bench. You can do the bench. You can do a few chest presses. You can do a few sit to stand. Then you walk the dog again. Yeah. So both of you have done their workouts. When you come home, you see a ledge, do a few step ups. That's what I always try to tell people, that and they needed to do exercises. And when they walk, I call my group the walkie-talkies because all they do is constantly just yapping while I talk. So they forget about the speed. And that's the good thing about with the Nordic walking, because the two poles separate the people. Yeah. And at the same time, you have a continuous speed. Yeah. And it's about obviously being the brisk walking, as we just heard before, is a very important part. And when they get into it, and when they exercise more often, when they get out with their friends again, and they can go out and show like a brisk walk on an unsealed trail again, then it makes you happier. Yeah, but some actually don't know they're not happy anymore because it's just what became to their life. Yeah, so we all get to that stage, unfortunately, or hopefully not. And then my business, well, I say stay active for life. Resting is rusting. I will tell the people. Yeah, so there's little things. When people hear them, they're like, oh, yeah, that makes sense. And that's funny. Yeah. And that's what they need. Yeah. We need to have a connection. We have to have a connection with fitness again. We have to have a connection with exercises, and not always hearing like most people I work with, they usually say, oh, exercise, it's a chore. I don't really like doing it. Yeah. But maybe then the Tai Chi is good for you. They don't even know about Tai Chi, but if they get the opportunity to get through all those different exercises, they might actually find something that actually ties in with what they love. So for those people that don't know what's happening around in Perth, or if there's groups, there's plenty of groups around, and you can always reach out to me as well. And I'm happy to go anywhere and talk them through those exercise programs, because that's one of my passions. I want to see people moving at any age and any stage. And if that's the outcome we get, then hopefully nobody ever has a fall. Yeah. But that's the best case scenario. And then obviously if they had a fall, it's a bit of a different pathway, but we have a few people that went through the physio path and then they came back and then joined exercise programs again because they know they can. Yeah, so there's lots of ways of how we can actually get people to move, but the most important way for me is that everyone enjoys a healthy lifestyle for as long as possible. Best case, we close our eyes one day and that's it. Thank you very much for having me.
Thank you, Hannes. A great example of a fun community-based activity that can complement the work that we're all doing. I can just imagine the energy that you bring to your classes. I'd like to welcome our final speaker for tonight, Balana Diaz. Balana is our Injury Prevention Officer of Workforce Engagement at Injury Matters. Welcome.
Okay, hello everyone. I'm sure we're eager to eat, so I will try and make this as quick as possible. The final falls guideline we'll explore today is recommendation 6, provide older people at increased risk of falls, home and community safety education in addition to exercise. So how can we achieve this? One way we can provide this falls prevention education to older people is through awareness raising. An awareness raising approach is a key strategy used to deliver falls prevention information, as it enables us to share accurate, accessible, and easy to understand health information. It is cost effective as it reaches large populations and provides a strong foundation for behaviour change, as it encourages individuals to reflect on their lifestyle whilst also providing clear solutions they can adopt. An effective awareness raising program should be planned and organised. It should be guided by a behaviour change model and tailored clearly towards older adults. This means considering key factors such as demographics, literacy levels, cultural attitudes, and their needs. Here's an example of the health belief model. This model helps explain and predict health-related behaviours. It is based on the principle that people's actions are influenced by their perceptions of health risks and the potential benefits of taking the preventative measures. The health belief model is just one example. There are many others, including the social cognitive theory and diffusion of innovation. For awareness raising to be successful, it should include these elements: clear information and guidance on the health issue and what can be done to reduce the risk of falls, and also distributing free or low-cost resources to facilitate and motivate the actual adoption of the new behaviours. So what strategies can we use to raise awareness? Common initiatives include mass media, community engagement, resources, and a website. Mass media campaigns provide a cost-effective strategy that can reach entire populations and drive meaningful change by shaping social norms and community culture. Examples of mass media include print media, radio, TV ads, and social media. Community engagement is important as it directly engages with older adults. This can provide more tailored messaging that aligns with learning styles and cultural considerations. Examples of community engagement include events, workshops, presentations, and newsletters. Resources are important in awareness raising because, because they provide the actual source of change. Resources should be designed with older adults in mind, considering visuals, information, and design. Examples of resources include brochures, fact sheets, videos, and checklists. And a website acts as a source of truth and a one-stop shop for accurate information. So what does this look like in real life? I'm going to use our Stay on Your Feet program as an example. The Stay on Your Feet program aims to improve awareness of the risk of falls, that falls are preventable, and the importance of healthy aging. We use mass media campaigns, community engagement, resources, and our website to do this. Our mass media campaign is used to extend the reach of falls prevention by challenging community perceptions of healthy aging. The Stay on Your Feet program delivers 2 3-month-long social marketing campaigns each year. These rotate between Move Your Body, Improve Your Health, and Remove Hazards. We are currently in our Move Your Body campaign, providing information on the importance of improving balance, mobility, and strength to prevent falls and support healthy aging. This is done through a combination of TV ads, radio, print advertising, social media, campaign toolkits, and unpaid media activities. Because most of you aren't in our target group, you may not have seen our new TV ad. We have recently developed 3 TVC ads that align with our campaign messaging. I'd now like to show you the one that aligns with our Move Your Body campaign. Oh, you can't hear it. But moving your body a little every day goes a long way to prevent falls. Stay on your feet. Oh, no, I've broken it.
Share it again. Hang on. Yeah,
Yeah.
Which side's the speaker on? Because we can just use that.
I have no idea.
Let's try again. It's not even coming out of the computer.
Okay, you can watch this TVC ad on Channel 7, or it's also in our Move Your Body campaign toolkit. I shall move on. Our community engagement is used to improve awareness, attitudes, and knowledge of falls risk factors and provide strategies for older adults to change behaviour to prevent falls. Stay on Your Feet community engagement leverages of adult learning techniques and peer-led education. The community engagement is done through a combination of peer education presentations, community events, community newsletters, and our inquiry support service. Stay on Your Feet also has an e-learning platform to provide education to regional older adults. Instead of me talking about it, let me show you one of the videos. We don't need sound for that, so that should be okay. Thank you. Okay, I'll quickly play the mass video.
The risk of a life-changing fall increases. But moving your body a little every day goes a long way in preventing a fall. Stay on your feet.
Our resources are used to increase community awareness, knowledge, and understanding of the modifiable risk factors for falls, including within hard-to-reach groups. The resources also engage our secondary target audience, health and community workers, with our program, providing them with evidence-informed information which they can share with their older adult clients. The Stay on Your Feet resources support our Move, Improve, Remove campaign and have tailored resources for our priority populations, Aboriginal and Torres Strait Islander communities, and culturally and linguistically diverse communities. Our website is used to increase older adults' access to falls prevention information. It acts as a tool to encourage effective falls prevention behaviours. We've made sure that our messaging is clear, credible, actionable, and evidence-based. Messaging should be engaging. Think slip, swap, slap, reduce, reuse, recycle, or in our case, move, improve, remove. Our messaging aims to encourage participation rather than cause fear. The Stay on Your Feet campaign was created and is constantly in consultation with stakeholders and the community, ensuring the success of the campaign. Awareness raising works. It was noted that in 2024, 41% of older adults who were surveyed recalled seeing our Move, Improve, Remove TV ads. And of that, 85% were able to recall our message that falls are preventable. This really highlights the importance of awareness raising. Raising awareness of falls prevention can be integrated into your roles simply by sharing our resources or referring them to our website. Thank you.
Thank you so much, Balana. And I just wanted to say a huge thank you to all of our speakers from tonight. We've had a lot of practical advice and information provided across a range of differing and complementing disciplines. I won't hold you too much longer in between getting your food. But I would like to remind everyone to complete their feedback or evaluation form. For those that are online, you can scan the QR code on the screen. Those in person, you can also scan the QR code, but you also do have a hard copy of our evaluation form in your packs. Like it was mentioned earlier, this really does help to guide the different types of trainings and professional development events that we provide for you. So please do take the time to complete these so that we can tailor our work to your needs. I'll just quickly touch on a few of the online learning modules that we have through our Stay on Your Feet program for health professionals. We've got Introduction to Falls Prevention, which just provides exactly that, just a nice little introduction into falls, risk factors for falls, and how to identify falls risks among older adults. We also have an exercise strategies and screening for falls prevention e-learning, which runs through assessing falls risk, gait mobility, strength and balance, the evidence that supports these falls prevention strategies for exercise. And then finally, our most recently released e-learning, falls prevention for community aged care workers. And this e-learning is for support workers or community care workers to increase knowledge around how to identify and report falls risk among their clients. All of our e-learnings are free and accessible through our Injury Matters website. And then finally, just a few, I guess, areas of how you can continue to connect with us and to continue to connect with the falls prevention sector. We have a monthly falls prevention e-news that we always recommend subscribe to, and our community falls network. So I know that Suzanne did touch on this before, but our community falls network, it really is your space to connect with like-minded health professionals that are working across WA in falls prevention. The falls guidelines are a timely topic for us at the moment. So if you want a space where you can talk about the guidelines, share your learnings, share your challenges, and just discuss this within a group setting, then reach out to us about the Community Falls Network. And that wraps us up for tonight. We've got some food out in the foyer, so please help yourselves.